Thank you for having me today, and it's really an interesting session. I really love talking about motion preservation. I feel like we're pushing for our patients. I do have relevant disclosure, just basic consulting with Permia. I don't have any royalties on this device, but that is relevant today. So we're going to be talking about this, and this is a case that really got me into it. I just found this technology because I was trying to find something for this gentleman. A 48-year-old male, healthy, exercises a lot. He's telling me about, like, he goes snowboarding all the time, but he's unable to do so. He's unable to continue living this way because of symptoms. He's got this degenerative spondylolisthesis at 4-5 with pretty significant stenosis. You can see that the facet joints are a little bit enlarged. There's that T2 signal within the joint. And the CT then shows these arthritic facets. It also shows air in the 5-1 disc, and I'm kind of thinking, oh crap, do I have to do a 2-level ALIF on this patient? He has like a high pelvic incidence. If you go back to the X-ray, are we, what can we do? I don't think a laminectomy is going to be a good idea. And so I found this. He was the first patient I treated about 1 year ago, and I think he was, kind of worked out perfectly, and I've been incorporating it ever since. I think patients are doing super well with this technology. It's a little bit interesting, and I'll go through a few more cases where we basically do a complete facet joint osteotomy, put in pedicle screws, and then place this TOPS device. And so, again, I'm just really grateful for these individuals involved in this clinical trial. I think it's amazing that they were able to publish this. The prospective randomized surgical trial, as we've seen, there's not been a lot of them. And a special thanks to Dr. Korik, who I've been texting about cases as I go, and I just saw him somewhere around here, but thank you. He's been reviewing them for me and telling me, yep, go ahead, you're good to go, basically. So this study was able to enroll close to 300 patients, with 206 in the arthroplasty group and 93 in the fusion group. And these are just the patient characteristics. Patients did not know what surgery they were going to have until immediately post-op. And so, this was the only way they were able to get this device at the time. It was subsequently approved by the FDA for placement in 2023. This was published in 2024. So this is the basic outcome metrics, patient-reported outcomes, showing improvement in all of those metrics with significance, except for the AS leg there. But all the others did have improvement over, well, the control group was an open TLIF with interbody made of PEEK. And this is the surgical complications, and these are just listed out here. And then the re-operations are noted here. They did note, basically at the 2-year point, that there was some lucency noted in about 7.9% of the replacement group in the around the pedicle screws. So personally, I've been reserving it for people with good bone density, but they do say that it's approved for up to a T-score of -2. And so a couple of these were durotomies. There was a higher adjacent segment disease rate that was significant in the fusion group. 5 patients in the fusion group underwent surgery for adjacent segment disease, and that was significant. So I'll just go through a few more cases of mine that I've been doing this for, and I'll show you why it's been cool. This guy basically has an L5 radiculopathy with a spondylolisthesis at 4-5 and a prior laminectomy. So it's kind of a perfect MIS TLIF case, or something. Maybe you could do another decompression there, but probably not. I'd be curious to hear what people say. But anyway, so we treated him with this device. Again, he did super well. He actually found me specifically looking for this, and I said, shout out to Dr. Korik, and okay, let's do it. And he's done well from that. Occasional soreness, he's like 4 to 6 months out. Here's another one. This is where I really think this is pretty powerful. 7-year-old with mostly mechanical back pain and some claudication, and retired police officer, somewhat obese, history of 30 epidurals, which is great. You see that quite often. So he has this degenerative spondylolisthesis at 4-5, but he has stenosis basically from facet arthropathy, lateral recess stenosis at 4-5, and also at 5-1. And now you're thinking, okay, so are you going to fuse at 4-5 and just decompress at 5-1? I don't know that that's appetizing to a lot of people. So then are you going to do a 2-level fusion? Then you get to CT and it's like, oh boy, he's got air in all the disc spaces. Are we looking at like a L1 to S1, or what are we going to do for this guy? So basically, I took him for the TOPS placement at 4.5 and then just a central decompression at 5.1. You can see there that we do the full facetectomy, and I think that that's where the power is, at least one point. Two is that they can kind of compensate and move that level still with this device in, and that's been shown. And I think that's why they do well. I'll just run through two more. Bone mechanic with claudication, high pelvic incidence, again with an LLPI mismatch of about 10, and really degenerative joint, severe stenosis. This one's on the borderline just because of the disc collapse, because in the trial they say 4 millimeters is where they're putting it, but I think it's still okay. And he's done super well. He's only 3 months out. And then lastly, this attorney that I treated 3 months ago with, again, similar problem, and I felt like that was perfect for this device. So there is some long-term data from the Israeli surgeons, and they have 9 patients with 11-year follow-up. In this study, this was, I think, maybe the original study, all international, and they had 1 device failure at 12 weeks just because the device was found to be locked, and there was a failure of the internal core. But the rest of the patients have done extremely well, 9 to an 11-year follow-up. And so it enables superior decompression. And I was thinking about it the other day, if you look at the incisions, I'm a neurosurgeon, so I don't really know, but if you look at the incisions people have for knee and hip replacements, they're pretty big. So sometimes with motion preservation, it requires a little bit bigger incision. A TLIF can be done in 1 hour through a stap incision, but